Welcome to the Aging Adult Health Lecture for NUR 152. In this lecture, we'll be talking about the physiologic and mental health concerns that we see in the aging adult and how the nurse can best care for this specialized group of individuals. Let's first start with the development of the middle-aged adult, which is age 40 to 65. There are physiologic, cognitive, and psychosocial changes that will be noted in this age group. You will see gradual internal and external physiologic changes that occur. Since this age group is about 25 years, you won't see those happening quickly. It will be a gradual change in those physiologic changes. Cognitive, you see little change from young adulthood. There is actually an increased motivation to learn in this age group. Oftentimes, you'll see that this age group goes back to school or wants to learn something new as they, start. So physiologic, you're going to see a gradual internal and external physiologic change that occur over time. Since there is a 25-year age range in this group, those changes won't be noted, within a year or two. They're going to be noted gradually over time. As far as cognitive goes, there is little change from young adulthood. We're going to see an increased motivation to learn. A lot of times these individuals might go back to school, they might want to gain new knowledge about a hobby or a skill, and their problem-solving abilities remain consistent throughout this age range. As far as psychosocial goes, time of increased personal freedom, economic stability, and social relationships. So the middle adult years, oftentimes we have that increased personal freedom because at that point, children are going off to college, parents are still well enough to live on their own. So we have that time to have that personal freedom where we start to focus on ourselves more, maybe create those new hobbies, learn new things, and get new things in our lives that we didn't have before. As far as psychosocial, this is a time of increased personal freedom because the responsibilities decrease as our children start to move out to go to college, our parents are still living on their own, and so you have that time to learn new things, get new hobbies. You focus on economic stability, so getting ready for retirement. Maybe you're putting away that money at that point so that way you're able to retire at 65. And social relationships, thinking about how our friends become more like family because our family is starting to get older. Our children move out, they become, the parents themselves, and they are focusing on their families at that time. So question number 2 here for you guys. So let's do a question here. Which example is a developmental task of the middle adult? Okay, if you said answer A, you're absolutely correct. We are going to continue an established lifestyle or reorganize one's life in a period of transition. You can read the rationale there if you want some more information on that. So moving on here, we have physiologic changes that occur in middle adult years. This box is from your book, so you can look through this, but for some examples, fatty tissue is redistributed. So males tend to develop abdominal fat and females thicken through the middle, in the midline area. Wrinkles start to appear on the face. You might start to see gray hairs. Males will start to lose their hair. Muscle mass, strength, and agility gradually decreases throughout those years. Fatigue increases. There are changes in vision and hearing that you will note. So individuals will start to wear glasses or hearing aids during this time frame. And hormone production does decrease, resulting in menopause and andropause for individuals within this middle adult years. Let's look at some psychosocial development. According to Erikson, which we'll focus on in this lecture, Erikson had a stage for middle adults called generativity versus stagnation. During this stage, the individual would guide the next generation, accept and adjust to physical changes, maintain a satisfactory occupation, assist children to become responsible adults, adjust to aging parents, and reevaluate goals and accomplishments. If the individual is generative, hence the generativity, then they're doing all of these things. They feel like they're doing something for the next generation. They are trying to guide the next generation, accept the changes that they're going through, and they feel pretty good about all of these things. If they do not achieve these tasks, they tend to focus on themselves, becoming overly concerned with their own physical and emotional health needs, and then they are in this sense of stagnation. They're stagnant. They're not doing anything to really help with the next generation or help maintain a satisfactory occupation or accept those changes. So they're more stagnant than they are generative in that sense. Adjusting to the changes of middle adulthood. There's a couple examples. So employment. Middle-aged adults may experience changes in employment. They might start to think about if they're satisfied in their job. Do they want to go back to school? Do they want to have a career change? Maybe they've lost their job. So they're having maybe some changes in the employment, or maybe they're satisfied in what they're doing and they're happy with their employment status. Spousal relationships can change. They can maintain. So it really depends on the patient. Maybe they feel a greater sense of security and stability with stronger emotional commitment and sharing with their spouse or partner, or they might feel like they're dissatisfied in their relationship and they might, get a divorce or find a different partner. That could be the case for some individuals. So you really have to assess where the individual's at. Relationships with children and aging family members changes. So middle-aged adults might be caught in what's called a generation sandwich. So they have their children at home, maybe college-age children or older children, and then they're taking care of their parents. So they're kind of stuck in the middle, hence the generation sandwich. Maybe they feel a sense of what's called empty nest syndrome, where their children have moved out and they no longer have children in the home. So they have all this extra time and space and independence, and they have no idea what to do with it because their whole sense of being was related to their children living at home. So all of these things are things that the nurse should consider to see how are they adjusting to these changes. Are they doing pretty well with them, or are they feeling like they need some support from the nurse? Moral and spiritual development. As nurses, we tend to ask questions related to someone's spirituality, faith, or religion. We might think about how do they feel in those areas? Are they having any spiritual distress, or do they feel pretty confident in their spirituality or faith or religion? They may remain at a conventional level or move to a post-conventional level. They might be a little less rigid in this stage of life with their beliefs, and they may question previous beliefs and be a little more open to hearing other people's perspectives of things. Some common health problems in middle adulthood. The number one cause of death in this middle age group is malignant neoplasms as of 2019. That was noted to be the leading cause of death. We also have things like cardiovascular disease, injury, accidental injuries such as falls, motor vehicle accidents, poisonings of some sort, depression and suicide. So thinking about some of those changes that are occurring, the patient might start to feel isolated or a lack of, they might become isolated or feel like they're not doing anything to help the next generation and become depressed or isolated. Diabetes for this age group, a lot of these have to do with the risk of obesity and the increased risk of obesity due to a more sedentary lifestyle. So oftentimes the individuals in this age group are taking in the same amount of calories they were in their younger years, but their activity level is decreasing. So that risk of obesity goes up. That leads to the cardiovascular disease, diabetes, cerebrovascular causes of problems. Chronic lower respiratory disease. So if the patient is a smoker or has been a smoker for a long time, obviously they're at increased risk for chronic lower respiratory disease, and we need to assess that in them. Liver and or kidney disease, as our organs start to change, as we start to intake potentially more substances, medications, alcohol can be a problem in the middle-aged adult. So we need to assess if they have a problem with alcoholism, because that can affect the liver and or kidneys. And then arthritis, as our bones start to have changes, as they start to demineralize, calcium is depleted, that puts us at risk for some of those changes in our bones. Arthritis changes due to the bone and the joints as well. So tell whether the following statement is true or false. Both acute and chronic illnesses are more likely to occur in middle adulthood and recovery takes longer. So that is true. Both acute and chronic illnesses are more likely to occur in the middle adult and recovery does take longer. Roles of the nurse. So what can we do as the nurse to help individuals within the middle-aged adult range? We need to start promoting health-related screenings, exams, and immunizations. There is a table in your book that goes over all of the screenings, exams, and immunizations that are appropriate for this age group. Some examples might be a prostate exam or a mammogram or a colorectal cancer screening. All of those things are going to fall within this age group of 40 to 65. Even a bone density screening is going to occur closer to the top of that age group. Teach the dangers of substance use, smoking, and alcohol consumption. So even though these individuals are middle-aged, we still need to teach them about using substances, smoking, and alcohol consumption, and trying to do those things in moderation. The alcohol consumption should be in moderation. We shouldn't be smoking, and we shouldn't be doing any type of substance use or abuse. Teaching adults to eat Teaching adults to eat a diet low in fat and cholesterol, so making sure they're doing those things to reduce the risk of heart disease, diabetes, cerebral vascular concerns. Teach the importance of regular exercise, so we typically exercise less as we get older. It's just So the role of the nurse in the health of the middle adult, we want to think about some health-related screenings, exams, and immunizations, which are very important. There is a table in your book that goes over these in greater detail. Some examples that I can think of would be doing our prostate exams, our mammograms. There are some immunizations that fall within this age group, a shingle shot, obviously the flu annually, and our colorectal cancer screenings. As the individual gets older, towards the higher end of the 65-year-old range, we're talking about maybe some bone density screening and things like that. So definitely review that table so we can help promote those screenings, exams, and immunizations to these individuals. We want to teach the dangers of substance use, smoking, and alcohol consumption. So alcohol consumption, if at all, is in moderation to help with minimizing those risk factors associated with alcohol consumption. No substance abuse, and obviously we want to encourage cessation of smoking if possible. We want to teach the adults to eat a low fat and cholesterol diet to reduce those risks of heart disease, cardiovascular disease, and diabetes, and teaching the importance of regular exercise. So middle-aged adults sometimes do not exercise as much as they used to, but they're still eating a high-calorie diet. So we want to make sure that we're encouraging them to exercise regularly based on their individual needs. So let's talk about the older adults now. This is our age 65 plus. Same changes that are going to occur related to the So let's talk about the development of the older adult, age 65 plus. So we have physiologic, cognitive, and psychosocial changes that you're going to note in these individuals. The physiologic that you're going to see is a progressive decrease in the efficiency of processes in the body. In older adults, the organ systems undergo some degree of decline in overall functioning, and the body becomes less efficient. There is a good table in the book that goes over the physiologic changes noted in the older adult. Cognition does not change appreciably with aging. Actually, intelligence increases well into the 60s and learning continues throughout life. So older adults can learn and they enjoy learning. It is normal for them to take longer to respond and react. So that's something you need to consider as the nurse, particularly in those new and unfamiliar surroundings. So as the nurse, if you know that it takes them a little bit longer to respond, you might pace yourself and adapt your education based on their needs. Psychosocial, they typically have a good self-concept throughout their adult life. An older adult who has a strong self-concept and self-identity has successfully met challenges earlier in life will probably continue to do so. This person may substitute new roles such as volunteer roles or leadership roles in maybe where they're living and their community for old roles, and perhaps continue former roles in a new context. Let's talk about some variation in life expectancy. As the nurse, we need to think about these things when we're caring for the older adult. We need to think about their socioeconomic status. Are they living on a fixed income? Are they solely relying on Social Security and Medicare for all of their bills? They have a reduced income at this point because likely they are retired. Some might be working, but most are retired over the age of 65. So any deviation from the budget that they have for themselves each month can be very stressful for that individual and family. Also, race and ethnicity factors. So knowing how that can impact their care. Are they within a race or ethnicity that has a higher risk factor for a certain disease, such as cardiac disease or diabetes? That's going to affect that individual's life expectancy. So intervening early, knowing those things, can reduce those risks and potentially prolong their life expectancy. Behavioral risk factors. So thinking about, are they partaking in any behaviors that might put them at risk? Due to the fact that they have some sensory changes, some visual changes, they're at a fall risk, all of those things can impact their life expectancy. Also, that decreased reaction time. So, when they're driving, if they are still driving, their reaction time might be slower, increasing their risk of accidental injuries. Healthcare factors. So, do they have access to good healthcare? Are they close by healthcare area, facilities? Do they have the means to go to those healthcare facilities? Do they have transportation? All of those things are going to be variations that can affect somebody's life expectancy. And as the nurse, you need to consider those things, take them into account so you can intervene early and reduce these risks. Let's talk about ageism. Ageism is based in stereotypes. So there are common myths that we have about older adults. Old age begins at age 65. Most older adults are in long-term care facilities. Older adults are sick and mental deterioration occurs. Older adults are not interested in sex. Older adults do not care how they look and are lonely. Bladder problems are a problem of aging. Older adults do not deserve aggressive treatment for illness, and older adults cannot learn new things. So all of these, as you guys can see, are not true, right? So there are some individuals that live in long-term care facilities, but a lot of individuals that are older live in their own home. They're living with their spouse. Maybe as they get older, they start to live on their own. Older adults it's not normal for an older adult to have mental deterioration. And you don't want to miss something as a nurse because you have this stereotype that deterioration is normal. Remember, cognition is not affected. We might have some loss of short-term memory, but if you're noting that it's happening more often, or you note that there are other symptoms, you'd want to investigate that a little bit more because a mental deterioration is not normal in an older adult. Older adults do like to engage in social activities. They are still interested in sex with their partner. We still need to focus on safe sex practices among the older adult population. Older adults do care what they look like. Maybe they don't have as much energy to put into their presence, but definitely they do care and they want to appear clean and, practicing good hygiene. Bladder problems, you want to make sure that you're not assuming that that's a normal finding. Yes, it is normal to have nighttime, which is called nocturia, toileting. However, if you're noting that it's increased at all or there's other symptoms, we don't want to disregard that, just assuming that's a normal finding. All right, so question here. Tell whether the following statement is true or false. Fundamental to ageism is the view that older people are the same as younger people, therefore they experience the same desires, needs, and concerns as other age groups. If you said false, you're absolutely right. Older people have a lot of the same desires, needs, and concerns as other age groups. Okay, so let's look at those physiologic changes of the older adult. Once again, that is in your book in a nice table in a lot more detail. I pulled a few examples out to talk about, but that table goes into greater detail. So talking about the integumentary system, you are going to note wrinkling and sagging of the skin. They do have a decrease in elasticity, so you will see the sagging of the skin in relation to that. They do often have drying and scaling are more common in this age group. The musculoskeletal system, the muscle mass and strength decreases, bone demineralization occurs, bones become porous and brittle, so we are at increased risk of fracture in this age group. The neurologic system, the central nervous system does respond more slowly to multiple stimuli, so the cognitive and behavioral response of the older adult may be delayed. Also, they can have difficulty processing multiple stimuli, so they might feel overload of those stimulus and have difficulty, processing all of that at once and might go into sensory overload. So there is a delay in their behavioral response. Special senses, diminished hearing and vision. So oftentimes these individuals are wearing glasses or hearing aids if they have hearing impairment. Cardiopulmonary system, the blood vessels become less elastic and often rigid, and so their blood pressure might be increased at that point. The venous return becomes less efficient. Gastrointestinal system, the digestive juices continue to diminish and nutrient absorption decreases. Dentition, we do have tooth decay and loss. It does continue for most older adults, so we want to make sure we're promoting good oral hygiene and assessing their teeth and what diet they're able to have based on what teeth they do have left and if they need dentures or not. Genitourinary system, the bladder capacity does decrease by about 50%. Voiding does become more frequent. 2 or 3 times a night is usual. That's called nocturia. But if you're starting to see that that's increased or there's any other symptoms, you don't want to disregard that and just assume that that's a normal finding. A decrease in the bladder and sphincter muscles may result in stress incontinence or incomplete bladder emptying, which is called overflow incontinence. And a lot of those individuals wear Depends or briefs of some sort to help with that concern. Let's talk about the cognitive development in older adults. Intelligence does increase well into the 60s, and cognition does not change appreciably with aging. So we want to make sure we're not making an assumption like that's a normal finding, if they're forgetful or their forgetfulness is becoming more, So cognitive development in older adults. Intelligence increases well into the 60s, and cognition does not change appreciably with aging. If you're seeing a change in cognition that is inconsistent with the patient, their previous assessments, you want to make sure that you investigate more with that. We do note that their response and reaction times may be decreased, so we're going to have to take that into account as the nurse. Mild short-term memory or more recent memory loss is common. Keeping a calendar or maybe writing things down on sticky notes is very helpful for that. Long-term memory usually remains intact. Dementia, Alzheimer's disease, depression, and delirium may occur and cause cognitive impairment. We want to make sure if we're seeing any cognitive impairment, we're definitely investigating a little bit with that individual. Let's talk about the psychosocial development of older adults. Self-concept is relatively stable throughout the adult life. An older adult may substitute activities such as new hobbies, volunteer, taking a leadership role in something, but they could disengage from society. They may isolate. They might not feel like as connected as they were before with society. Erickson stated that these individuals go through what's called ego integrity versus despair and disgust. This is where they do a life review. They start to reflect and say, do I feel like my life was fulfilling? Do I feel like I met the developmental tasks that I wanted to meet? Do I feel like happy or a sense of joy from what I did in my life? If not, they might be in despair. That's when they might isolate and get some depression and have difficulty with activities of daily living. Adjusting to changes of older adulthood. These are things that we need to focus on with our older adults. Their physical strength and health. So how do they adjust to that? So looking at adjusting to changes of older adulthood, physical strength and health. So are they modifying their lifestyle to accommodate for declining strength and health? Do they rest more frequently? Are they taking breaks? Are they focusing on their diet? Are they focusing on exercising? Retirement and reduced income. Are they doing things that bring them joy in their retirement? Are they feeling fulfilled? Are they living within their means and able to, you know, are they able to Are they doing things in their retirement that bring them joy and that fulfill their life? Are they living within their means of their reduced income? Do they have money for the housing that they need, the medical bills that they need, maybe social activities? Spouse or partner health, are they adjusting to those changes in their own health or their partner's health? Are they taking care of themselves? Or are they taking care of an ill partner? That's all things to think about as the nurse, as we think about caregiver role strain or them focusing more on their partner's health than their own. Relating to one age group, so sometimes older individuals don't feel like they're as old as their counterparts. Are they able to socialize with those in their age group? Do they go to a community center? Do they socialize? Do they go to outings? Are they part of any social groups or maybe some activity groups? Social roles, are they feeling valued? Are they feeling useful and productive? If they don't feel these things, they might start to become isolated or depressed. We can encourage them to volunteer, to have leadership roles within their community to help them feel that sense of value and production. Living arrangements, where are they living? Are they adapting to where they're living? Do they live on their own? Do they live in a assisted living type community? Do they live in a 55 plus community? Do they live by themselves? So really adjusting well to those changes in their living situations is really important to determine if they're able to meet their individual. So their living arrangements, are they living on their own? Are they living in assisted living? Are they living with a spouse? Maybe in a center of some sort, a long-term care center. So thinking about if those living arrangements are meeting their functional health needs. Do they have transportation to and from their home? Do they have family support systems as well? And their role reversal, are their children taking care of them? Are they taking care of maybe their children in some way? So thinking about speaking about living arrangements, assessing, are they adjusting well to their living arrangements? Do they live by themselves? Do they live in a retirement community of some sort? Do they live in assisted living? Where are they living and are they adjusting to those changes? Also, family and role reversal. Do they live with their family? Do they take care of their spouse or their partner? Maybe their children are taking care of them, and how are they adjusting to these changes? Moral and spiritual development. Older adults have completed their moral development. So when we talk about that, they're typically living by a set of rules that they have agreed to based on maybe society's rules and expectations. We have to assess their spirituality, their faith, and their religion. Do they feel like they're at a good place with their spiritual development? And do they have any needs? Are they in any spiritual distress? A lot of older adults trust in a greater power. As they start thinking about, nearing death as they get older, they want to believe in a greater power and maybe something after death. And that's something you want to explore with that individual. Health of the older adult. So looking at health, most older adults are not impaired. They live on their own. They take care of themselves. They complete their own ADLs. They're not living in a long-term care facility, and they are healthy for their age. They are more vulnerable to physical, emotional, and socioeconomic problems. So remember, guys, they're living on a fixed income. Their reserves are lower emotionally and physically. Their bodies are starting to become a little less efficient. So probability of becoming ill increases as their immune system, everything slows down a little bit, and it takes them longer to get better when they do get ill. Diversity in chronic illness, so thinking about, are they within a certain type of group of individuals that health concerns are higher? So heart disease, diabetes, maybe cancers. We have to think about those things when caring for the older adult individual. Polypharmacy, are they taking a lot of medications that have side effects that are making them feel drowsy, dizzy, at increased risk of injury? Chronic health problems or disability may develop in this stage. Accidental injury, because of changes in those things like vision, hearing, loss of muscle strength and mass, slower reflexes and reaction time, and decreased sensory ability. So if an individual of this age group has a fear of falling or is driving and has that decreased reaction time, they are at increased risk of accidental injuries. Dementia, delirium, depression are things that we have to be alert to as nurses caring for older adults. We will have a lecture on these things separately, but just making sure that if you see any signs or symptoms that are inconsistent with previous assessments, you want to be alert to those things and investigate a little bit more. Remember, delirium is reversible, right? So dementia is typically irreversible, but delirium is reversible. So whatever's causing that delirium, once we care for that problem, it will go away. The delirium will go away. Depression is occurring in these individuals. They are at higher risk because of the changes that are occurring. They have extreme or prolonged sadness because they're maybe not having as many friends. There's death occurring of their spouse, their friends. They have different changes in their living environment, their financial resources, their independence if they're no longer driving. So a lot of things go into that in relation to depression in the older adult. And then elder abuse. Obviously, elder abuse is something that is more highlighted because the number of adults that are living longer has increased. And so we have more of an awareness of this problem with our elder population. These individuals are at risk because oftentimes they are So elder abuse is another concern. We want to make sure that we are monitoring our older adults for elder abuse. It can be different forms of abuse. It can be neglect, it can be financial abuse, physical, emotional, sexual abuse. So we really need to make sure we're monitoring our older adult clients for these things. Tell whether the following statement is true or false. Sundowning syndrome is a temporary state of confusion that can last from hours to weeks and resolves with treatment. That's false. So remember, guys, delirium is a temporary state of confusion that can last from hours to weeks and resolves with treatment. Causes of accidental injury in older adults. This is its own slide because accidental injuries are a leading cause of health-related visits to the emergency room for our older adult population. Oftentimes, the changes in their vision and hearing are the result. So causes of accidental injuries in older adults is an individual slide here because it is a increased risk for individuals within this age group. It is a leading cause of visits to the emergency room and hospitalization in this age group. Changes in vision and hearing put them at risk for falls, for accidental injuries, loss of muscle and strength of muscles. That slower reflexes and reaction time is an increased risk, especially if they're driving. They are at an increased risk of falls from that as well. Decreased sensory ability goes into play as well. So causes of accidental injury in older adults are related to these things here. The reason why this slide is separate is because older adults are at increased risk of accidental injuries such as falls, motor vehicle accidents, and So causes of accidental injury in older adults, this is an individual slide here because of its importance. Older adults So causes of accidental injury in older adults is a separate slide here because of the increased risk to this population. Changes in vision and hearing, loss of mass and strength of muscles, that slower reflex time and reaction time, decreased sensory ability, those medications that they're taking, so that polypharmacy and those chronic illnesses that occur, and economic factors can put these individuals at increased risks of accidental injuries. Falls are a huge risk factor in the older adult population. Chronic illnesses and medications as well, because the patient may be more prone to accidents due to the side effects or the inabilities that they have based on their chronic illness. Older adults with reduced income may live in inadequate housing, in neighborhoods with heavy traffic or high crime rates. They might also be isolated from family members. So let's talk about the assessment tool, SPICES tool. This is a tool used for our older adult population where we look at these couple things. We look at sleep disorders. Are they having any difficulty with sleeping, or do they have any diagnosed sleep disorders? Do they have any problems with eating or feeding? Do they have incontinence? Are they confused in any way, more than normal? So let's talk about the assessment tool, which is called the SPICES tool. The SPICES tool, we look at a couple things. We look at sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, and skin breakdown. This tool is very helpful in identifying problems with these areas, and this tool can be used in many settings that will help to alert the nurse to problems in these areas, and then we're able to early intervene. Identify interventions that'll work to help reduce the risks and individualize care for the patient. Let's talk about some nursing actions to promote health in older adults. We can maintain physiologic reserves. We can help to promote physiologic reserves with good health care, early identification of problems and risk factors. We want to always maintain ongoing assessments for early detection of these problems. For cognitive function, we can slow the pace of activities and wait for responses. For psychosocial needs, we can assess and support sources of strength, including cultural and spiritual values and rituals. Nutrition, we want to assess for loss or damaged teeth, ensure that dentures fit properly, provide foods appropriate to the patient's ability to chew. Make sure they're eating a balanced diet. If they have any difficulties with nutrition, we can definitely get some support for them. Maybe there's some services that would bring meals, offer them discounted meals, or they're able to get food stamps. Sleep and rest. Assess their normal bedtime, time for rising, bedtime rituals, effects of pain, medication, anxiety, and depression. All of those things are going to affect their sleep and rest and their bedtime. So nutrition, we're going to assess for lost or damaged teeth, ensure that the dentures fit properly if they have dentures, make sure their dentures are being cared for properly, provide food that is appropriate to the patient's ability to chew, and make sure that the patient is eating nutritious meals. If they're having difficulty getting meals, we can definitely help them to find services that might offer discounted meals or even free meals to their home. Sleep and rest, we want to assess their normal bedtime. When do they wake up? Do they have any rituals? Are they having any pain, medications, anxiety, or depression that's affecting their sleep? And we're assessing those things and helping them work through them. Elimination, assess the frequency of bladder elimination as well as problems with incontinence. Activity and exercise, assess their ability to walk, ensure they're using any assistive devices if they need those. Also encouraging them to have exercise based on their individual needs a couple times a week. Sexuality, we want to assist as necessary with hygiene, hair care, oral care, clean clothing, bedding, makeup, and shaving so that they're able to meet their sexual needs. Meeting developmental tasks, promote continued development and maintenance of functional health by identifying those unmet tasks, feelings of isolation, or physical and sensory limitations. So we want to see where they're at based on thinking about Erikson's developmental tasks, are they feeling like they're accomplished, or are they feeling like they've had some unmet tasks, and how can we help them meet those tasks so they don't feel so isolated where they're at? All right, guys, so that's the conclusion of All right, guys, so that's the end of our Aging Adult Health lecture. We'll talk more about this when we meet in lecture. If you have any questions before then, feel free to reach out. If not, I will see you then.